friendship in the years to come. Well, friends, Calicut, I'm really proud that you are again come back with this new series, and your immunology and something which is, as Narayan sir has put it, it is something which is there in every specialty and something which is in the hoping down the line. Maybe Dr. Kishore and others will be there to impress upon how immunology is closely linked with everything. And I'm one person who is very much there with allergy, and allergy is basically not allergy and immunology now. Now respiratory, everything is asthma, and everything goes in immunology. So it's all lot to have some understanding, better insights, genomics, everything has got a great role to play in our understanding of diseases. And well, of course, this webinar series is sure to deliver a lot into our making us better equipped and better in knowledge, and that way better equips us to handle these situations. I'm quite thankful. I wish that the webinar series all success. I'm quite thankful to all my good friends here, and I don't see Suresh here. Suresh was the secretary after me, and he was one person who was always motivating me from. I don't see him here on, but all my great friends are here. And thanks again, my great friends in IAP Kozhikode and IAP Kerala for taking me up to the IAP reigns in the coming years, and I am sure, and I hope that I will do justice to your expectations, and I hope the seminar series here will do wonders for the better understanding into the immunology coming up. Wishing the best for the IAP Kozhikode and the webinar series. Thank you. Jai IAP, Jai Hind. Thank you.
Thank you, Dr. Ramesh. We are very happy and proud to have you in Calicut after your big win, even though virtually. Thank you. Now I invite our National Vice President, Dr. Ananda Keshavan, a dynamic academician for National Vice Presidents.
Very good evening. Respected Chairperson Dr. Ajit, IAP State President Dr. Narayanan, Secretary Bala, Kozhikode President Ashraf and Naha, previous State President Dr. V.K. Parthi Madam, Sushma Madam, HOD of Pediatrics Past Dr. Sachidan Sir, Sudha Madam, and other my dear friends, and my dear student Dr. Kishore Chandra Kichu. Very happy to see you, Kichu, after a long time. It is always any IAP meeting, Calicut meeting is also homecoming, because we can see our students, we can see our teachers, we can see our classmates, juniors, seniors. Dr. Jayagrishan is there, Dr. Krishna is there, Dr. Vijay Kumar is there. So it is just like a homecoming. It's always happy to attend it. And another aspect is that how IAP Kozhikode, it is not the Ashraf and Nahian Buddhiana, different topics are coming like that. Immunology and such a, it may be Gita Govindra, something, I don't know, but anyway, a very fascinating topic, rare topic, and it is upcoming topic. If it is infection, there is immunology. If there is the immunization, immunology is there. If it is the collagen hospital, MISI, everything immunology is there. So I think it is a real, they selected a topic in our time and also a very good, wonderful topics. Kishore, I am seeing Kishore after a long time. He's our student also. I think now he's my teacher anyway. And happy to see Kishore after a long time. And I wish the CME all the success. And once again, I thank the organizing people for inviting me for this meeting. Thank you. Jai Hind, Jai Hind.
Thank you, Dr. Ananda Keshavan. You are always is a part of Calicut IAP, definitely. Okay, thank you. Now I invite Dr. Geeta Govind Raj, the coordinator of this program. She is a professor of pediatrics, Government Medical College Calicut, and actually Geeta started her specialty clinic dealing with acquired immunodeficiency, children living with HIV, and slowly moved to primary immunodeficiency, a topic of interest and importance nowadays, as Dr. Narayanan and Ananda Keshavan said. I invite Dr. Geeta to give a clinical perspective of this scientific series. Over to you, Dr. Geeta.
Thank you, Dr. Ashraf. Recurrent fever is one of the most vexing problems we deal with. And once infections, autoimmune conditions, and malignancies have been ruled out, one certainly needs to factor in autoinflammatory syndromes in the list of differential diagnosis. This series of 6 lectures on autoinflammatory syndromes is an endeavor to bring these enigmatic disorders that commonly present in childhood out of the shadows and into the spotlight. They are often misdiagnosed, resulting in therapeutic misadventures, including surgical procedures and treatment with immunosuppressive medications. These disorders are not as rare as they were once thought to be, and several of them are eminently treatable. We are fortunate to have a panel of world-renowned experts, including Professor Dan Kastner, who actually discovered these disorders, Professor Helen Lackman, Professor Yannick Crow, both from the UK, Dr. Ozga Basaran from Turkey, who will be talking about familial Mediterranean fever, Dr. Marco Gattorno from the renowned Gasolini Institute in Italy, apart from Dr. Kishore Warrier, who will introduce all of us to the topic. Confirmation of the diagnosis usually requires the help of the molecular geneticist, which is why we have Dr. Vinod Skaria, Principal Scientist at CSIR Institute of Genomics and Integrative Biology, to speak next. Over to you, Dr. Vinod.
Thank you, Geeta. Geeta already invited Dr. Vinod, even though I once more invite him. He's a researcher. Actually, Vinod is also an alumni of Calicut Government Medical College. Now he's the principal scientist in the CSIR Institute of Genomics. Out to you, Dr. Vinod.
Thank you, sir. So today's educational series is actually a culmination of almost 5 years ago investment into primary immunodeficiency disorders. Well, when we started this cohort of primary immunodeficiency disorders almost 5 years ago, close to 6 years now, there were trickle of patients coming in, getting diagnosed, suspected, so on and so forth. And now today we have close to 300 patients who have been suspected to have primary immunodeficiency disorders, over 100 patients who have been molecularly diagnosed to have primary immunodeficiency condition, and probably making it one of the largest cohorts of its kind, probably in this part of the country. And the most fortunate part is that a significant number of patients have been, are today alive, because otherwise these are lethal conditions, are today alive and have accessed multiple kinds of treatment modalities with the support of the Kerala government. And that's essentially what motivates researchers like me to spend more time and spend more effort in trying to unravel many of these conditions. And just to give numbers, primary immunodeficiency disorders are actually the largest class of genetic disorders, with today over 400 genes implicated in any one of these conditions. And yeah, hopefully this is also the start of many new things that will come up, not just in diagnosing patients, but also discovering new genes, and also probably being able to help many of these children who still remain undiagnosed despite the best of our efforts. Thank you.
Thank you, Dr. Vinod. Vinod belongs to 42nd batch of MBBS at Calicut Medical College. Now I invite our dynamic secretary Balachandar. Is very busy with arranging the reports for the IAP activities of the last year, even though he's in this platform. Over to you, Dr. Balachandar, to felicitate. Okay.
Thank you, sir. Respected chairperson of the day, Dr. Ajit Kumar, our President Narayan sir, our National Vice President Andreeshan sir, our President-elect Ramesh Kumar sir, our experts Geeta ma'am and Dr. Vinod Skaria, our speaker of today's session, Dr. Kishore Warrier, Secretary Nihas, Ranjit, Ajay, all seniors of IAP Kozhikode and our state, and my friends. Today, I am extremely happy to be part of this third academic extravaganza by IAP Kozhikode this year. We are all thankful to IAP Kozhikode for pumping in so much academics, which we won't get much by reading textbooks. After the Rainbow series and the Doyen series, the seminar on PID, primary immunodeficiencies, a condition which we should have a high index of suspicion. Actually, we have a chapter on allergy and applied immunology from Central IAP. Actually, even though allergic diseases are much discussed in that. Recently, we had topics on immunodeficiencies also in the chapter conferences. We know there are experts in this field in IMCH Kozhikode, Geeta ma'am, and also Dr. Vinod Skaria, alumni of Kozhikode Medical College. I am lucky to hear from him during our rare diseases CME at ICONS Shornur this year. So I congratulate the pillars of this seminar, Dr. Geeta and Dr. Vinod, and also Ashok sir and Nihas, the team IMCH, for organizing this wonderful academics for the next 6 weeks. And wish this conference the very best and this seminar the very best, and happy learning to all. Thank you.
Thank you, Dr. Balachandar. And next Friday onwards, there will not be any inaugural session. After an opening remarks, we will directly go to the speaker. And this is the end of the inaugural function. Before that, I invite Dr. Nihas Nehar, Dynamic Secretary of IAP Calicut, for a vote of thanks. Dr. Nihas, over to you. Nihas? Nihas? Yes, Nihas.
Hello.
Okay. You are audible.
Okay, sir. Respected Chairperson Ajit sir, Narayan sir, Ramesh Kumar sir, and all other delegates who joined us today. First of all, I'd like to thank Geeta madam and Vinod sir and the team for giving us the opportunity, IAP Kozhikode, the opportunity to host this webinar series. Thank you, madam, and your team for conducting excellent work in this field and coming up with an excellent series of speakers from all over the world who are the doyens in this field to the IAP Calicut. I like to thank Ajit sir for presiding this meeting. Our dear President Narayan sir, any time for us, he is there for inaugurating this session. Ramesh sir, our National President 2021, Andhra Keshavan sir, our National Vice President, and all other delegates who joined us, to seniors, teachers, and my dear friends who have joined us today. I thank you all for joining us, and I'm not taking a lot of time. We are already 15 minutes late. So we need to keep this on time. From next session onward, we won't be having any inaugural session. We'll be directly going to the sessions. Thank you all. We'll start with the session. I also like to thank our speaker today, Dr. Kishore, for being there with us today and taking this nice inaugural session. Thank you, sir. And thank you all for joining us today. We'll start with the session.
Thank you, Dr. Nihas. Now we are moving to the scientific session. And today's topic is there a recurrent theme? Introduction and case-based discussion by Dr. Kishore Warrier. And the session will be chaired by Dr. P. Geeta, Additional Professor of Pediatrics, Government Medical College, Calicut. She is in charge of Pediatric Rheumatology at Government Medical College, Calicut. I invite Dr. Geeta to introduce the speaker as well as to introduce the topic. Over to you, Dr. Geeta.
Thank you, Ashraf. Am I audible? Hello?
You are audible.
So, on behalf of IAP and Department of Pediatrics and the CSIR Institute, I'm extremely happy, proud, and privileged to introduce Dr. Kishore Warrier from UK. Though he's presently at UK, he's actually one of us. He spends a month every year at Kerala, I know, and he always keeps connections with us. He's actually undergraduate from Trichure Medical College, but he did his post-graduation from Calicut and also Trichure Medical Colleges. And he had his formal training in pediatric rheumatology from Newcastle, and he's a consultant in pediatric and adolescent rheumatology at Nottingham Children's Hospital since 2013. He's a member UK Systemic Autoinflammatory Diseases Group and also the JDM Group, and he's a convener British Society for Rheumatology Conference 2020, and his special areas of interest are autoinflammatory diseases and inflammatory myopathies. And actually speaking, we from Calicut Medical College are extremely proud of him. He has scaled great heights, in his career. And in spite of being a brilliant academician, as Dr. Ashraf said, he was a very dynamic person in the department way back in 2019, 99, 2000. He's an all-rounder actually. He sings well. He has got an in-depth knowledge in Carnatic ragas. He's a good percussionist, and he also belongs to the prestigious Kottakkal Ayurveda, family of Malappuram district. So over to Kishore for kicking off this exciting series of lectures in pediatric immunology, focusing on autoinflammatory disorders, a very interesting topic. So he's going to take us through a cluster of case scenarios. Kishore, please.
Okay, Kishore, your screen is visible. Go for the slideshow.
Kishore, you are muted, I think.
Kishore, you are muted. Please unmute yourself, Kishore.
Kishore, please unmute.
Yeah. You are muted again. Please unmute.
Can you hear me now?
Yes.
Now you are audible, Kishore. Okay. Go
on. Is the screen visible? Are the slides visible?
Yeah, slides are visible. It's very
First
clear.
of all, thank you very much for all the kind words. As I said, it's an absolute privilege and honor to be amidst you doing this session and starting this webinar series. It is quite daunting to be doing this talk in the midst of so many of my esteemed teachers. Parvati Madam has been my professor during my undergraduate days and then a mentor during my postgraduate days, my time as lecturer in Thrissur Medical College. Sushma Madam was my examiner for DCH. And Lulu Madam, again, was my teacher, mentor, and she was always encouraging my other pastures as well. And all the my teachers in Calicut Medical College, it's difficult to go through by each name, but it's an absolute honor to be doing this session in your presence. I have a few disclaimers to make. First of all, I am not an immunologist. I am a pediatric rheumatologist, and we only deal with the overactive immune system. So I have my knowledge on primary immunodeficiency is fairly primitive, and I wouldn't be best placed to answer any questions on that. But we like to deal with the overactive immune system because we know a thing or two about immunosuppression. So that is my remit in this specialty. So when Geeta Madam approached me to kind of do this seminar, it so happened that it was one of my areas of interest, and I'm one of the members of the Systemic Autoinflammatory Diseases panel we have in UK. So I was more than happy to do this session. So many thanks to Geeta Madam, Calicut Medical College, IAP Calicut, and all other organizers for having me do this talk. The second disclaimer I have to make is I'm going to make this very simple because you are going to have experts in their respective fields. Now, if you look at the rest of the speakers, they are clearly experts in their field, unlike me, because I'm just a rheumatologist who does a bit of autoinflammatory diseases, whereas many of them are doyens in their field. So you are going to obviously hear and learn from them as we go by. So my aim is just to introduce the subject and briefly describe the conditions and illustrate them through a few cases. with that introduction, I think I'll go to my first slide. So the roadmap for today would be, I'll be introducing you to the concept of autoinflammatory diseases without going into any great molecular detail. Periodic fevers, what is periodic fever? And a brief overview of systemic autoinflammatory diseases that cause periodic fever. Diagnostic challenges. So what are the clinical and laboratory clues in the diagnosis of a periodic fever or an autoinflammatory or a monogenic periodic fever rather? What are the, again, very brief principles of management? And then I'll illustrate this through 2 cases. I know we have started a bit late and I'm kind of notorious to overrun my lectures anyway. So when you think it's a time to stop, just ask me. There is no problem. A few disclaimers. As I said, the focus is essentially on a clinical approach. What should a general pediatrician, or when should the penny drop for a general pediatrician, or when should a general pediatrician be suspecting an autoinflammatory disease? So I'm not going into the inflammasome and all the molecular details. It's essentially focused on clinical approach. A list of systemic autoinflammatory diseases are exhausting and almost growing by the day. I will confine my focus to periodic fevers. I will have a very brief overview of individual conditions. So I will not be going into each condition at length because we are going to have experts talking about that in great detail. And I'm struggling a little bit to apply this to the Indian context because my experience with autoinflammatory diseases while working in India is quite limited. But I've tried to get a couple of slides from my Indian colleagues, which might actually throw more light on this. So the very basic question when we discuss autoinflammatory diseases and periodic fever is, what is the definition of fever? And it's universally accepted that any temperature more than 38 degrees Celsius or 100.4 degree Fahrenheit is accepted as fever. We have a lot of patients referred to as with recurrent fever, but if you look at the fever chart, they would have had temperatures of 37.4, 37.5. So it is not a fever, so it's not a recurrent fever at all. So once we talk about fever, we have essentially 3 main things in our mind. Is this infection? Is this inflammation? Or is this neoplasia? There are other rare causes, but these are the 3 common things that would come to our mind. So I'm going to focus on the inflammation bit of this differential diagnosis. And when you talk about inflammation causing fevers, you're talking about periodic fever versus persistent fever. And I'm going to confine my discussion to periodic fevers. So, as I said, a brief introduction to autoinflammatory diseases. So when I was doing my microbiology and immunology, we were kind of talking in terms of cell-mediated immunity and humoral immunity. Now, the 2 broad classification of the immune system is innate immunity and adaptive immunity. Now, innate immunity, as you all know, is a rapid, non-specific immune response, which has got no immunological memory. So it's very primitive, but it can be quite catastrophic. Whereas adaptive immunity is much more sophisticated, clever immune response, which develops more slowly, which is more specific in and has got immunological memory. So we need to have this concept to understand the difference between autoinflammatory and autoimmune conditions. So autoinflammatory diseases, which are the remit of discussion today, are essentially a problem with the innate immunity. And the major players here are macrophages and monocytes. Unlike autoimmune diseases like JIA or lupus, which is a problem with an adaptive immunity, and the main players are the lymphocytes. Again, similarly, the cytokines which are involved are also different because you often get an inflammatory storm in autoinflammatory diseases, and the main players there are the interleukins, which is important from a treatment point of view because you would want to target them to get the better response. Whereas autoimmune diseases are essentially kind of TNF driven and other markers rather than interleukins, especially interleukin 1. So the examples are all the inherited monogenic periodic fevers we are going to discuss today, like CAPS, FMF, TRAPS, HITS, etc. Certain multifactorial conditions like PFAPA syndrome, acquired conditions, most commonly Still's disease, and some rare conditions which are now deemed as autoinflammatory, like gout and Schnitzler syndrome, which are not applicable to the pediatric population. Most of the classical autoimmune conditions like GIA, Crohn's disease, psoriasis, lupus, Wegener's, which is now called granulomatosis polyangiitis, are all examples of classical autoimmune diseases, but not autoinflammatory. So summarizing, autoinflammatory diseases are classified, include conditions which are monogenic, which means a single mutation explains the pathogenesis, or multifactorial, as in PFAPA syndrome, which could be infection / genetic / environmental. Inflammatory conditions which are characterized by an exaggerated activation of innate immunity in response to exogenous or endogenous stimuli in the absence of high titer autoantibodies. So basically, this definition not only describes autoinflammatory conditions, but also excludes autoimmune conditions. But this is an interesting slide, which I have borrowed from one of my colleagues. So although we kind of tend to categorize them separately as autoinflammatory and autoimmune diseases, it is not a clear-cut classification. It is a spectrum. For example, if you look at conditions like FMF and CAPS and TRAPS, they are predominantly autoinflammatory. And as you go further down, for example, if you go to Still's disease, it has got both autoinflammatory, predominantly autoinflammatory, and some autoimmune elements. And as you further go down, it's predominantly autoimmune and very little autoinflammatory. So you can get a patient with lupus who has got a bit of macrophage inactivation syndrome, which is an cytokine storm. It's an autoinflammatory process. But it is predominantly autoimmune, but a small element of autoinflammatory. So what I was trying to say is it's not as black and white and compartmentalized as I said earlier. It is a mixture. So the periodic fevers, the monogenic periodic fevers are more autoinflammatory when compared to conditions like lupus and GIA, which are more autoimmune. So when should one suspect autoinflammatory disorders? What are the symptoms? If they are inherited, most often the onset is early. Early means the first few years of life. It could even be in the first year of life. One of the most important defining symptoms is fever. Again, the fever could be periodic or persistent. And for academic discussion for monogenic inherited disorders, I shall confine the discussion to periodic fevers today. What is the predominant laboratory manifestation or the laboratory characteristics of autoinflammatory disorders? They have spectacularly raised inflammatory markers, CRP, ESR, ferritin. And serum amyloid A is one thing which is very important because it is actually a persistent elevation of serum amyloid A, which can define organ damage going forward. And it is not just a mild elevation. So if you are in a, for example, if it's a systemic onset GIA or somebody who's got CAPS, they often have CRPs in hundreds, ESR in 50 to 100, and ferritin often in thousands. So all these inflammatory markers are quite significantly elevated than you would expect in an autoimmune or infective situation. They may have symptoms pertaining to various other systems depending on the diagnosis. Skin rashes are very common. In fact, they help us diagnose or nail down the diagnosis. GI symptoms, abdominal pain, diarrhea, vomiting, musculoskeletal manifestations. They can have joint pain, myalgia, fasciitis, etc. Chest symptoms, mainly because of pleuritic chest pain, especially in conditions like FMF. So basically, they have serositis. Eye manifestations, which is, I'll come to which condition you get these, and sometimes hematological manifestations, and even what we call a macrophage activation syndrome as a complication. But the most important point is, whenever you suspect autoinflammatory disorders, we do not embark on any kind of treatment unless we have made sure that we have ruled out infection and malignancy, which are the most important differential diagnosis. Because the medications we are going to throw at them would be steroids or other immunosuppressants, which can be catastrophic if you have missed leukemia, for example. So this is a brief overview of, I think if you look at autoinflammatory disorders, I just listened to Dan Kastner about 2 months back, and there are new autoinflammatory disorders being discovered almost on a daily basis. So this is a list as it stood probably about 3 or 4 years back. So the most important categories, as I said, periodic fever, the monogenic periodic fevers. Then there are conditions called cryopyrinopathy or CAPS, cryopyrin-associated periodic syndrome. Then there are some granulomatous disorders like Blau syndrome. So basically, Blau syndrome is an autoinflammatory inherited equivalent of sarcoidosis in children. Sarcoid in the classical form is very rare in children, but Blau syndrome is a sarcoid-like inherited illness in syndrome. There are certain pyogenic disorders. There are certain autoinflammatory disorders that affect bone, like CRMO, which is chronic recurrent multifocal osteomyelitis. And there are certain miscellaneous conditions like DIRA, which is a problem with interleukin-1 receptors. And there is another broad category called interferonopathies, about which Professor Yannick Crow, who is a good friend of mine, is going to talk in a few weeks' time. But this is a broad classification, but I'm going to confine my discussion to the autoinflammatory disorders which cause periodic fevers. So the first question then is, what is periodic fever? When is recurrent fever a periodic fever? Obviously, we don't call it periodic fever unless it's recurrent. So it has to be recurrent. But the most important thing is it most often is predictable. So if you speak to a child with FMF or PFAPA even, the parents are often able to say that he's going to have an attack next week. So the timing is so predictable. And that sets it apart from any other recurrent fevers. For example, recurrent fevers because of recurrent tonsillitis or whatever. So one important aspect is the predictability. So the second thing is stereotype, because they have the same symptoms with fever every time. So in January, you get fever with runny nose. In February, you get fever with sore throat. In April, you get fever with diarrhea and vomiting. That is not stereotypy. So they're probably all different viral infections. Whereas before we call it periodic fever, we need to make sure that there is a stereotypic element to these episodes, both in terms of symptoms and in terms of the rough duration. The other classical feature is the children are completely well in between, although there are exceptions, which I'll come to later, but usually the children are completely well between the episodes. Now, symptoms last a few days and they go away. Why should we even bother to investigate or refer these patients? First of all, morbidity, because in many of these conditions, the children are so unwell during an episode, they often miss school. So for a child who is missing about 12 to 20 days of school every year, it's a significant effect on education and everything. You can have long-term life-limiting complications, most notoriously amyloidosis. So many of the patients can go on to have renal amyloidosis and renal failure in their third or fourth decade in time. And then inherited monogenic periodic fevers have other implications because you need to think about genetic counseling and other things because this could be transmitted to the next generation. So I need to, I'm indebted to my colleagues for this slide because it's not my slide, I've just borrowed it. So if you look at periodic fevers or recurrent fevers as a broad outline, this would be the differential diagnosis. So we need to think about multifactorial inflammatory diseases, infectious diseases, as we have mentioned. It could be a recurrent infection in a child who has got an underlying primary immunodeficiency. So if you've got recurrent infections, too many infections in the first few years of life, we would naturally think about a primary immunodeficiency, which is very important. And I'm so pleased it's kind of, investigations and are available now more freely in India. Then you need to think about neoplasia because neoplasms can cause recurrent or persistent fever as well. And then the category of inherited autoinflammatory diseases. So I would like to start my individual conditions with a fairly common multifactorial. So this is not monogenic. It's not monogenic inherited condition. It's a multifactorial inflammatory disease called PFAPA syndrome. So PFAPA syndrome, as the name implies, is a combination of periodic fever with aphthous stomatitis, pharyngitis, and cervical adenitis. This is by far the commonest cause of periodic fever in children. It was first described by Dr. Marshall in 1987, and some people call it Marshall syndrome. Now, there is no clear explanation for the etiology. It is clearly not a monogenic inherited condition. However, there are lots of studies which have picked up mutations in certain other periodic fever genes like NLRP3 or the FMF gene in these patients. And there are some studies which kind of postulate an infective trigger. So the cause is not really known, but is thought to be a mixture of genetic, environmental, and infective triggers. These children usually present before 5 years of age with episodes of fever. Each episode usually lasts anywhere between 3 to 6 days, usually less than a week. And they recur anywhere between 1 to 2 months or 4 to 8 weeks. But as the definition implies, the fever is usually associated with at least one of the 3 main symptoms. So that would be aphthous ulcers, cervical lymphadenopathy, or pharyngitis. On the longer term, prognosis is generally good because this tends to resolve by adolescence. But there is no clear indicator as to whether it resolves at 11 years, whether it's 15 years, 17 years, we don't know. Because I've got patients who've had it well into their 13, 14 years of age. But there is a good chance that this is self-resolved. And there is no significant risk of long-term complication like renal failure. So the diagnostic criteria for PFAPA are fairly loose in the sense you can fit in these criteria for a number of other conditions. So the one thing is, as I said, regularly recurring fever with early age of onset. So the regularity also translates to predictability and stereotypy of episodes. These patients usually have constitutional symptoms in the absence of upper respiratory infection. So if they're having a cold or runny nose, that is not PFAPA syndrome. Then obviously you have at least one of the 3 things which we mentioned, and they're completely asymptomatic, back to normal between episodes. And usually this does not affect their growth or development. However, as you can easily say, the specificity is poor because anybody who has got recurrent aphthous ulcers could satisfy this criteria. Anybody who's got recurrent streptococcal sore throat could satisfy this criteria. So the criteria are fairly loose and with poor specificity. However, a new set of criteria has been proposed by a group in Europe, which has been validated. So it is the new classification criteria is on the left in this chart. I'm not going to go through this detail. So if you want the reference is usually at the bottom of my slide. Any article I've quoted should be at the bottom of the slide. But this is still being validated, and actually we are a part of an international consortium who are looking into validating this and doing a study on this. What is the treatment? So there are 2 ways of treating this. One is treat an episode, or 2 is try and stop an episode, prophylaxis. So treatment, it's actually very simple. We use prednisolone, often a single dose of 1 to 2 milligram per kilogram at the onset. And sometimes parents can even predict when the children become unwell, not even before they can actually get fever. And they usually have a rapid resolution of all symptoms. However, aphthous ulcers are probably is probably the symptom which is least responsive to steroids. But all of the symptoms, including fever, usually resolve. If there is no response in 12 hours, you can actually give a second dose. So sometimes what I advise is 1 milligram per kilogram at the start, and if there is no response, give another 1 milligram per kilogram 12 hours later. The slight problem in giving steroids is that in some patients, in fact, in quite a few patients, it can actually increase the frequency. So we had one patient who used to get episodes every 4 to 5 weeks. And once we started steroids, the parents were really happy that the symptoms went away. But then he started having these symptoms every kind of 3 to 4 weeks or even 3 weeks, which means that he was requiring steroids more often. There are some studies saying that you can use an anti-IL-1 agent like anakinra during episodes. So basically you give an injection of anakinra at the start of the episode, and that may abort this. Now, what are the medications which have been tried to reduce the frequency of flares or in a prophylaxis? The one we like to use or we like to try is colchicine, and it's used at a dose of 0.5 to 1 milligram, not per kilogram, 0.15 to 1 milligram once daily. Now, in America, they often use cimetidine at this dose, but the generally overall efficacy is considered to be much poorer than colchicine. Now, if you have come to the end of the tether to the extent that these symptoms are not going away with anything and the child has got significant morbidity and is affecting normal life, many of these patients, we could consider an adenotonsillectomy in these patients. In most of the studies, it definitely benefits patients. But if you look at, depending on your studies, you look from the 90s or until 2000s, the efficacy varies from anywhere from 60 to 100%. Because I have had 3 or 4 patients, all of who have had a complete resolution of symptoms. But we usually tend to reserve it for when the medical treatment fails or is not tolerated. Now we go to the inherited autoinflammatory diseases causing periodic fevers. So essentially they are fourfold: FMF, familial Mediterranean fever, mevalonate kinase deficiency or hyper IgD syndrome, TNF receptor associated periodic syndrome or TRAPS, and CAPS, which I said is cryopyrin associated periodic syndrome. So when do we suspect any of these conditions? When the onset is early, almost all of them have significant abdominal symptoms. It may be associated with diarrhea and vomiting. They may have chest pain because of serositis, and there is often a family history. So when I get somebody with a periodic fever, the 2 important things I look for is the first thing is the duration. How long is the episode? So the simple rule of the thumb is, if it's a familial Mediterranean fever, it's usually less than 72 hours. Whereas TRAPS, it's usually more than 7 days. Sometimes if it goes on to 7, 10 days, 14 days, it's more likely to be TRAPS. Whereas the hyper IgD syndrome, it's in between, about 3 to 7 days. So the most important question, one of the things I like to know in a patient with periodic fever is, how long does the episode last? So we've only yesterday seen a girl with a classical 48-hour history who's got chest pain, who's got abdominal pain, who we think has, and the family have come from Kurdistan, I think, Iraq, Kurdish Iraq. And there is a good likelihood that she has got FMF. So that's the duration is very important. The earliest symptom to ask, the easiest symptom to ask is abdominal symptoms. So these are the 3 conditions where you have predominant abdominal symptoms: HITS, TRAPS, and FMF. So if you go further into the symptoms, you can see that they all have a peritonitic abdominal pain, and some of them have vomiting and diarrhea. Interestingly, its constipation is more common in FMF, whereas in HITS, it is more vomiting in these patients. With regard to skin rash, you can get an erysipeloid skin rash in FMF. Most of these patients do have non-specific joint symptoms. But however, in TRAPS, you can get significant myalgia, focal myositis, fasciitis, etc. They usually don't have organomegaly except for HITS. So when you get a periodic fever patient with a splenomegaly, always think about HITS. Eye manifestations are more common in TRAPS. And many of these patients can also have some vasculitic effects, especially when you get a patient who's got recurrent HSP. That could be a manifestation, especially with fever, that could be a manifestation of some of the periodic fever syndromes, especially FMF. So we've got a girl who has presented initially as HSP, kept having HSP episodes with fever, and she responded really well to colchicine. Now, with regards to genetic, FMF is autosomal recessive in the MEFV gene. TRAPS is actually an autosomal dominant mutation in what we call TNF-F1A. And MVK gene is the one which is affected by an autosomal recessive mutation in patients with HITS. The second set of conditions I said is CAPS, cryopyrin-associated periodic syndrome. Again, FCAS, or familial cold autoinflammatory syndrome, is probably the mildest variety. Most of these people, sometimes they get diagnosed in adulthood even, just some cold-induced urticaria, nothing at all, no significant elevation of neurological markers, inflammatory markers, and they don't have a long-term complication. Now, the most severe autoinflammatory syndrome is what we call NOMID or SINCA. So that's neonatal onset multisystem inflammatory disease. The onset is usually in early infancy, so which means 2 to 3 months. Sometimes in neonatal period, they can present as meningitis, which doesn't respond to treatment, sterile arthritis, osteomyelitis, etc. They usually present with musculoskeletal and neurological manifestations. They can also have an urticarial rash, but this is a condition which needs to be treated very early on because it can very quickly lead to brain damage, sensory neural hearing loss, eye problems, cortical visual blindness, and arthritis and contractures. So it is incredibly rare, but if you get a neonate who has got sepsis/meningitis/osteomyelitis, who have not grown any organisms but is unresponsive to antibiotics, think about NOMID. So how to differentiate between the different conditions? So the clinical features, as I said, are often shared. I would like to ask 3 key questions. One is the age of onset. When did the whole thing start? Often it can be very blurred answer in the sense they said, I think he's probably started after 1 year, but we only noted that this is coming again and again when he was 2 or 3. So you may not get an answer, but that vague answer is still good enough and to give you a clear idea of which condition this could be. The most important question for me is the duration of the attack. Is it, again, if they've got abdominal symptoms, I would always ask for, is it less than 3 days, 3 to 7 days, or more than 7 days? Then the frequency. So again, depends on which condition you're dealing with. Which system is affected? That's another important thing. As I said, if they've got abdominal symptoms, I would really be worried about FMF traps and hits. They can have neurological, in which case think about, you can have that in traps, you can have that in caps, and urticaria. So urticarial rashes are quite characteristic of caps, especially if they have cold-induced urticaria. Just one slide about FMF. We are going to have a whole lecture on FMF, but I'll just very quickly take you through FMF. Sorry, let me plug in my laptop. So as I said, it's an autosomal recessive condition with a mutation of MEFV gene. And there are hundreds of mutations identified. And sometimes we get a response saying that you've got this mutation. We don't know whether it's clinically significant or not, which is why it's very important to collaborate with the geneticist with the clinical picture so that you can arrive at the right conclusion whether the mutation is significant or not. Another very simple way of diagnosing FMF is if you're suspicious, give colchicine. If it is FMF, 99% of the time they will respond. So this is usually seen in classic ethnic groups. I'm yet to see a white, Caucasian, British girl or boy who has got FMF. Most of the patients who have got, they've definitely got some Middle East or even North Mediterranean, Italian or Spanish connection. The classical feature is the duration. As I said, the duration is usually only 1 to 3 days, usually less than 72 hours. The frequency can vary anywhere from 2 weeks to 6 weeks. The classical features are abdominal pain, chest pain, and joint pain. Sometimes they can get an erysipelas like erythema. So like you can see in this child, this is classical erysipelas like erythema, you get an FMF. But the biggest problem is, why do you need to treat them? Because this is associated with systemic amyloidosis, which can lead to renal failure. So even in adults who have presented with renal failure in their 30s and 40s, and there is amyloidosis, they all get referred to we have got something called a National Amyloidosis Center, and they have picked up so many FMFs retrospectively because they were not picked up. The treatment of choice is colchicine, which works in 99% of patients. So if you've got somebody with suspected FMF and colchicine is not working, it's unlikely that you're dealing with FMF. However, there is a small percentage of colchicine resistant FMF, in which case anti-IL-1 is the best treatment. So the dose of colchicine is quite high in patients with FMF. It's incredible how much colchicine these patients can tolerate. So we have got siblings from Lebanon, I think, who have FMF. And the girl is about 12 years. She's on 1.5 milligrams, which is actually, if you calculate per milligram per kilogram, it's actually a big dose. And the boy who's only 4 is tolerating 1 milligram without any problems. So most often these patients need a higher dose. I feel that Asian patients tolerate colchicine much, much better than Caucasian patients, where they often get diarrhea And sometimes we advise them to avoid lactose containing diets and slowly reintroduce back. TRAPS, or TNF receptor associated periodic syndrome, which used to be called Hibernian fever. It's very common in Irish population. It is again autosomal dominant mutation of TNFR1 gene. This is the one which has got the longest duration for the episodes. The patients have fever, abdominal pain, and other symptoms 2 weeks. And the interval naturally would be longer because the episodes last longer. It'll be probably 3 or 4 episodes every year. The migratory myalgia is usually identified as one important feature in these patients. As I said, they all have significant peritonitic abdominal pain. And I think there is a family who live in Nottingham, a Caucasian family, who have got TRAPS. And whenever that boy flares, he's got classical peritonic features. This is again one condition where you can significant eye symptoms. You can get either conjunctivitis or periorbital edema. Sometimes you can get pleuritic chest pain. You can get arthralgia. The raised inflammatory markers are usually elevated. But the important thing here is even between episodes, you may find that inflammatory markers are elevated in some of these patients. The treatment of choice is, you may feel that because this is a TNF receptor problem, anti-TNF would be the best agent. Unfortunately, it's not. So we could try things like etanercept or in these patients, which does work for a few years, but then slowly it stops working. And eventually you have to go to anti-IL-1, which is anakinra, which is given as a daily injection. I'll come to the medications very briefly a bit later. Again, the problem with TRAPS, if you don't pick up and treat in the right time, is they have a higher risk of systemic amyloidosis. So when we see a TRAPS patient and an FMF patient for annual review, we always check their serum amyloid levels and also do a urine dipstick for proteinuria. So this is the kind of migratory myalgia, and sometimes you can get the conjunctival content. You can get this is actually a skin rash overlying an area of myositis. And you can, I don't know if it's very clear, you can get a similar picture here as well. So sometimes you can get rashes overlying the area of muscle pain. And this is a fasciitis in a patient with TRAPS. You can see the fascia being inflamed. It looks really bright because of inflammation. Last but not the least, hyper IgD syndrome, which is otherwise called mevalonate kinase deficiency. This is in between TRAPS and FMF in terms of duration. It lasts about 3 to 7 days. Again, predominant symptom is abdominal pain. They often have cervical lymphadenopathy, arthritis, arthralgia. So these patients, again, if you take the abdominal pain aside, they can often be branded as PFAPA because the symptoms often overlap. But one important point is the onset can be before 1 year of age. There are not many conditions where you start having symptoms in the first year of life. So this is one of the conditions. They can get skin rash, and as one important feature is splenomegaly. So one of the few periodic fevers where you can, probably the highest incidence of splenomegaly is hyper IgD syndrome. Now, medications, you can try steroids during episodes. In Turkey and other places, they try thalidomide. You can try anti-TNF, but the best treatment is anti-IL-1 treatment again, which sadly is not available in India at this point in time. But the difference between TRAPS and FMF, the use of anti-IL-1 in HIDS is that the response may not be as good as other conditions. So we have a patient who has not actually done well on this. I'm not going to this criteria. Again, the article I'm quoting is at the bottom. So there is a new Eurofever diagnostic classification criteria for all these periodic fever syndromes. The beauty of this criteria is that they've got the symptoms which predominate or predominantly seen in these conditions, or they can also see, they are also quoting features which should make you rule out this condition. So absence is very important in these conditions. So with your kind permission, if I may go to all the cases, and as I said, Geeta madam, please feel free to stop me because I may go on and on. Are we all right time-wise?
Continue, Kishore.
Yeah, fine,
Okay.
fine.
Continue.
Yeah, so we've got the first one is a 6-year-old girl of mixed race. I was never conscious about the race, how important race is in our patients. And one of the things that made me sit up and take note of is autoinflammatory syndrome, because the ethnicity and the race does matter in many of these patients. So this girl basically has had recurrent fever since 9 months of age. The classical description is high-grade fever, 39 to 40 degrees, lasting 3 days, with abdominal pain, but no diarrhea or vomiting. She is also reported sore throat during some episodes and occasionally mouth ulcers, but the carer felt that the mouth ulcers probably were not related to the fever. They just were random episodes. Her past history, she had hemiplegic cerebral palsy of the right side with febrile convulsions, but there was no significant family history. Like most of the periodic fevers, the frustrating bit is they are usually completely normal when you see in the clinic during an interval between episodes. So apart from the spastic paraparesis, she would have been a very good long case for DCH or MD examination with her paraparesis, but apart from that, there was nothing much to see, and the investigations were completely normal. So what I told them is, I'm not going to do any blood test today. Could you please come back to us when she has the next episode? So one important aspect of assessing patients with periodic fever is to see them during an episode rather than between episodes, because you may not find any useful information either on clinical examination or laboratory investigation if you see them between episodes. So I didn't do any investigation, just asked her to come back. So when we actually saw her, she was on the second day of her symptoms. She had abdominal pain the previous morning and a temperature of 39.6 the previous evening. Apart from mild sore throat, there was nothing else. There was no mouth ulcers. When I examined her, she had actually congested throat with large tonsils, but there were no follicles or exudates. She had bilateral cervical lymphadenopathy. Abdomen was soft and non-tender. So at that point, my differential diagnosis were, am I dealing with an FMF? Because 3 days, abdominal pain, possible. The other differential diagnosis is the PFAPA, because she's got pharyngitis and cervical adenitis with periodic fever, which started before 5 years of age. And last but not the least, because the size of the tonsils, I wondered, is this a recurrent streptococcal infection, which is very plausible because you have patients who, and she's had multiple courses of antibiotics, and the carer couldn't tell me very clearly whether she actually got better because the antibiotics or got better spontaneously. So the investigation showed a elevated CRP of 33, but most of other investigations were normal. Her serum amyloid was 100. But again, serum amyloid during an episode doesn't tell you, because amyloid is an inflammatory marker as well. So it is important to check serum amyloid between episodes to look at the risk of amyloidosis. We also did a urine for mavaconic acid, which was negative, and her ASO titer was less than 200. And we had sent an autoinflammatory genetic screen specifically for FMF and HITS, because those are the two things she would have fitted in, and they both came back as negative. So I felt that because FMF is still high in the probability, the easiest way to understand is put them on colchicine. Because if it's FMF, they will respond to colchicine most often than not. So when we saw her again in 3 months, she was still getting 6 weekly episodes, but the grandmother was very clear that the episodes are much milder now. It's probably lasting only 24 hours, maximum 36 hours. So we thought we'll increase the colchicine dose to 750 micrograms. And in the next 6 months, she had 12 weeks with no episode at all, which is a good thing. But then just before she came in, she had an episode lasting 3 days. But grandmother said the difference is now she's got significant mouth ulcers. So we thought we'll still give her the benefit of doubt and put her on colchicine. Now, mouth ulcers make FMF slightly less likely. We are probably leaning towards PFAPA. But we thought we'll give her the benefit of doubt and maximize the dose of colchicine, which was increased to 1 milligram. But then when we saw her later, 3 months later, it was very clear that she was still getting episodes, although less frequent and still lasting 3 days. But now mouth ulcers had become a significant symptom with each episode, along with abdominal pain and sore throat. So then the differential diagnosis changed. We thought this is more probably PFAPA now at this point in time, because she should have responded to the dose of colchicine we have given if she had FMF. So we stopped colchicine and started, the advice was to give prednisolone 1 milligram per kilogram at the fever of attacks, at the start of the attacks. And she had an excellent response. So I saw her probably in October last year before, so she should be due an appointment soon. And she had only had 1 episode in the whole of preceding 12 months, and that too lasting only about 12 hours. That was what it is. So this retrospectively is PFAPA. I think if you are bent and making the diagnosis in the first time you see the patient, you are a bit wishful. This is an area where trial and error and repeated reviews definitely makes you wiser. The second girl is an Indian girl. I think she's the only Malayali patient I've had during my 15 years of practice in UK. She was having recurrent fever since 3 years of age. Again, the story was she was having an episode every 3 to 4 weeks, lasting about 48 hours. But the only symptom she was having was pain in her lower limbs, mainly thighs. So this was more like myalgia, not even arthralgia. There was no history of joint swelling. She had, however, they did say that during some of the episodes, she used to have sore throat and swollen glands. She did not have any other symptoms. And as always, she was completely well between episodes with no family history. When I saw her in the clinic, the examination was completely fine. However, she was seen by my colleague during an episode, and she had some raised elevation in her inflammatory markers. ESR was 21 and CRP was 33. So again, the question is this periodic fever? Again, if it's periodic fever, is this FMF? Highly unlikely. The duration fits in, but there is no abdominal or chest symptoms. It's just musculoskeletal symptoms, unlikely. Again, PFAPA, because they said of sore throat and glands, possibly there. But again, you don't expect musculoskeletal pain as a predominant symptom. And again, my question is this a recurrent streptococcal infection? You can get fever and musculoskeletal pain as a part of recurrent streptococcal infection. So investigation showed negative genetics for FMF, but her ASO titer came back very high, more than 1600. So it was unmeasurably high. So I didn't do anything. I just gave her a treatment dose of penicillin for 10 days, followed by put her on PEP prophylaxis. She had a normal echo with my fever, musculoskeletal pain, and high ASO titer. I was very brave. I would have been very brave not to do an echo. The echo was completely normal. So I just put her on penicillin prophylaxis for 1 year. And she had absolutely no episodes at all during this period. At the end of 1 year, I'd made sure that, I did another echo to make sure it was normal, and we stopped penicillin. She's never had a problem. So this is an example of a recurrent infection or probably a persistent streptococcal carriage masquerading as a periodic fever. So as I said, before we embark on any treatment in any of these conditions, it's important that we rule out infection and, if appropriate, neoplasia. This is another interesting girl who I see in a clinic which I do about 60 miles from her. This is again a very strange story. This is a white British girl who had recurrent fever since 3 years of age. Mom was saying she had some fevers during from 9 months, but she was not very clear. But definitely a stereotypic, predictable fever pattern since 3 months of age. 1 episode every month lasting 48 hours. But again, the only symptom she had was headache and fever, and sometimes photophobia. Said she didn't like bright lights during the episodes. She did not have musculoskeletal pain, abdominal pain, rashes, mouth ulcers, nothing at all. But she was clearly very tired and drained during the episodes that she was not going to school during the episodes. There is absolutely no family history, and she was completely well between. Again, she had normal examination, but one of my colleagues had seen the child during an acute episode, and she had a raised inflammatory marker of a CRP about 30 or 35 during this episode. Again, her autoinflammatory genetics came back as negative. And I thought this doesn't sound like PFAPA, but there's absolutely no harm because the frequency to try her on a bit of colchicine. We just put her on the lowest dose of 500 micrograms, and she had an excellent response. I don't know what this condition is. I would probably call it unclassified periodic fever syndrome. She doesn't have FMF, but she had a response to colchicine. So what the family themselves discontinued the medicine after about 18 months. And you know what? She started having a recurrence of these episodes. And then she went back to colchicine, and the episodes never happened again. Now, the important thing to remember is that her genetics was done using a Sanger sequencing. We didn't do a next generation sequencing, which is what we do, which look for entire set of panels. Maybe she's positive for something, I don't know, but she clearly doesn't fit in the textbook description of FMF. Again, the point is we need to try and err in periodic fevers to get it right eventually. Now, this girl is a very interesting girl. So we saw her at 8 years of age. She is a Slovakian Roma girl. So now, when you say Roma origin, the Roma Europeans have definitely got some South Asian lineage. They have brown skin and black hair, and it should have been something to do with the Silk Route migration or something. So most of them have mutations. We have found mutations in that family, which can be seen in some Asian populations. I don't know what the link is, but there is clearly, they look very Asian. So the story here is she has had problems from about 9 months of age, at least some 1 year of age. But here the episodes were clearly longer when compared to other patients. So she had episodes lasting 1 week, once every 4 weeks. So she would have 7 out of 28 days in a month would be miserable for her. So she would have fever, sore throat, abdominal pain, joint pain and stiffness, and sometimes mouth ulcers. She never had any rashes. And she had received multiple courses of antibiotics, but mother was very clear, even when we gave antibiotics, she should still have fever for 5 days. So that kind of told me that it was not the antibiotic doing the trick. It was more the episode kind of spontaneously resolving. If there was an option for Q&A, I would have kind of asked you guys what is the most likely diagnosis with that duration. So with that picture, the only different thing for her that she had Bell's palsy history of recurrent Bell's palsy in the past. And she also had one episode of HSP when the family were in Slovakia. And she's also been diagnosed with sensory neural hearing loss on one side. The school were concerned because she was missing a lot of school, but there was no significant family history. So on examination, she had a Bell's palsy, obvious still residual Bell palsy. She had big tonsils, but again, no follicles, no ulcers, no mouth ulcers. She had cervical lymphadenopathy, joints were normal, no hepatosplenomegaly. But her inflammatory markers were quite high. So we saw her between an episode, and she still had an ESR of 40 and CRP of 80. But when we looked at ASO titer, it was more than 1600. So 1600 was very high. And the throat swab was negative for streptococcus. So with that streptococcus very significant, titer is very significant, I thought the first thing we should do is treat her with penicillin and give her proton prophylaxis. We did that for 8 weeks. She had absolutely no response. She still had an episode lasting a week, both those months. By the time the autoinflammatory genetic screen had come back, showing that she's heterozygous for MKD mutation, which is HITS. Now, the problem is this is a heterozygous, this is an autosomal recessive condition. She was heterozygous for that mutation. But the clinical picture fitted in perfectly. She had abdominal pain, she had sore throat, she had lymphadenopathy, but no splenomegaly, but it usually lasted about 7 days, which was the perfect bill for MKD. So the clinical picture correlated. So these genetic results are read by Professor Helen Lackman, who is actually doing the talk next week, who we work together with these patients. So when we described the clinical picture, Helen said, although this is heterozygous, it's not one of the classical mutations, I think let us have the benefit of doubt and put this patient on anakinra, so which is anti-IL-1. However, she had a partial response. She had no episodes at all for 3 months, but then she started having small episodes with every period. So we don't, and that's when she had menarche. So we didn't know what this collection was. But then there are 2 questions here. Is that because this is not HITS? Or second question is that because this is a HITS which is not responsive to anakinra? So because she continued to have the sore throat and lymphadenopathy, she also kind of fitted with PFAPA syndrome. So we thought we would probably send her for a tonsillectomy to see what it does. And you know what? She had an excellent response. Once she had the tonsillectomy, all the episodes stopped and we stopped anakinra. So this is a case where you have a periodic fever who fits in a description of one condition perfectly, which is kind of semi-proven on the genetic test, but you give the right treatment, but the patient doesn't respond. So you just need to think outside the box. This patient also could have fit in the criteria for PFAPA because the episode lasted about 7 days. It's about 3 to 6 days in PFAPA. She had sore throat and she definitely satisfied the Marshall's criteria. And which is why we give her a suggestion for tonsillectomy, and it really worked for her. Am I okay to keep going?
Yeah.
Okay, Kishore.
Yeah, so this is a 3-year-old boy, again, very interesting, a white British young man who has been having fever since 18 months of age and regular episodes since 2 years of age. So basically the story is he definitely becomes clingy and tired, lethargic, off food. Then he develops abdominal pain and joint pain. And the next day he develops fever up to 39 to 40 degrees. So everything happens within 12 to 24 hours. He gets red cheeks, mom said, but no rashes. He definitely has got abdominal symptoms with diarrhea. And he gets joint pain to the extent that mother described him as walking like an old man on the morning when he got an episode. A typical episode would last anywhere from 2 to 4 days, but he was getting an episode every 3 weeks. And he's completely well in between, and somebody had already put him on prophylactic azithromycin, which did not work. So this was a symptom diary. So this is another important thing I would like to explain. When we are not sure about the periodicity and stuff, one of the things which we should ask parents to do is to keep a symptom diary, because nothing gives you more information than a visual representation. So in this patient, you can see that he had an episode for 3 days here. And after 8 days, he gets another episode lasting 2 days. Then after another 10 days, he gets an episode lasting 3 days. Similarly, there's one lasting 4 days. Then 2 weeks later, he gets another one lasting 3 days. Again, the temperature of 39.7. So basically, the story mother was telling us was actually we could get a visual representation, and we could easily understand why he was unwell for a lot of time. Apart from the cow's milk allergy, there was nothing at all in the family history. Initial blood tests were all normal during a clinic appointment because he looked completely well. And then we advised that they should contact us when he has the next episode. So when he came in with a fever, high fever, abdominal pain and diarrhea, and pain in the left elbow. So basically arthralgia, abdominal pain and high fever. His temperature was definitely 39, anywhere between 39 to 40. He was lethargic. There was no rashes. He had red lips, but again, nothing else to see. Mildly congested throat. No mouth ulcers, abdomen was soft, his joints were normal. So there was although there was arthralgia, there was no arthritis. And the episode lasted about 5 days. His inflammatory markers were definitely elevated. His hemoglobin was low, which was probably because of inflammation. White cell count was high, neutrophil count was high, ESR was high, CRP was high. So this is a classical picture you would get in inflammation. Anemia, neutrophilia, thrombocytosis, and raised CRP and ferritin. And his serum amyloid A came back as 434, which even during an episode is quite high because the normal is less than 50 for us. All his extended infection screen came back as negative. My colleague had already done an autoimmunodeficiency, some of the tests for the immunodeficiency, and this came back as negative. And autoinflammatory genetics, which was at the time Sanger sequencing, came back as negative for FMF hits and traps. So we thought, why don't we start colchicine and see what happens? Again, I'll probably skip this slide. And in December, we started colchicine at 500 micrograms. It's please read that's microgram. There was no response. We increased the dose, kept increasing the dose until we got to 1 milligram. And he actually had some response. He only had 4 brief episodes over a period of 6 months, which is the best he has been. But sadly, the episodes returned about 6 months later, and despite increasing to 1 milligram, he didn't tolerate it. So at this point, we thought we'll try him on prednisolone. So we'll try him as PFAPA. So give him a dose of prednisolone at the onset of symptoms and give another dose 12 hours later. Steroids definitely helped. Mom said as soon as he gets this steroids, he's absolutely fine. But the problem was that the episodes were getting more frequent. So from 2 to 3 weeks, now he was having one every 7 to 2 days, which means that he was having steroids every 7 to 2 days, which was kind of affecting his behavior, and he was becoming increasingly naughty and aggressive and stuff like that. So mother was partly happy, but not fully happy. But it was during this point when we saw him, we found that he was having some urticarial rashes. So the GP was treating that as allergy. So we thought, in a background of periodic fever, when you get urticarial rashes, we need to think about CAPS. So we revisited the genetic screen, sent off his blood again for an NGS panel. Actually, they had the sample already for CAPS. And then it showed up a rare mutation of NLRP3 gene. So Helen actually rang me with the result. And I said, Kishore, tell me the clinical picture. So I explained this is a clinical picture. And she said, I think it sounds like this is a perfect clinical picture for CAPS. This is a mutation which we are hitherto not found, but it's extremely rare in general population. This could possible that this is pathogenic. And we started anakinra as a trial. And you know what? She had an excellent response. So the diagnosis eventually was CAPS with a response to anakinra. My last case is a patient who I've been dealing with completely remotely. I've not seen this girl at all. It's all because of the COVID. We could not transfer patients between hospitals. It's purely from emails and telephone conversation. We finally reached the diagnosis. So this is a 3-month-old baby girl of Syrian origin who was born preterm 33 weeks with a birth weight of 2.56. Mother had type 2 diabetes, pregnancy-induced hypertension and preeclampsia, but the baby had received 2 doses of dexamethasone. There was mild respiratory distress at birth requiring CPAP for about 24 hours, and baby was started on IV antibiotics. But the problem was the baby had high CRP, and the antibiotics, when they started antibiotics after 48 hours, the CRP went up. So the CRP was always abnormal for this patient, anywhere between 20 and 160. Because of the same reason, the neonatal team kept chasing for infection. So the patient had multiple blood cultures, urine cultures, even a couple of lumbar punctures, but never grew anything. So she had multiple full septic screen, and it never grew any organisms. So this patient was referred to me whether this could be a systemic autoinflammatory disease. The family history was very, very crucial in this patient. So it was a consanguineous relationship. So parents were first cousins. There are a lot of history of sibling loss. There were 2 healthy boys aged 9 and 2 years, but they had lost 3 babies, all with different reasons. The first one sounded like a Vactal abnormality. The second baby had died of cirrhosis at 3 months of age. Again, we don't have any medical records. This is purely what the parents have told us. And they had another baby girl who passed away because of heart and brain abnormalities, but we don't have any records. But the interesting bit of history was maternal grandfather has a diagnosis of FMF as is on colchicine, and this patient's father's sister, a paternal aunt, has FMF and kidney failure, and she's awaiting kidney transplantation. So this is quite damning, this family history. So with that picture, we had to consider an autoinflammatory disease. So basically, the clinical picture is persistently raised inflammatory markers. So persistent anemia, raised CRP, high white cell count, and platelets even up to 1,000. So almost 10 lakhs. So that's how the platelets were, which is always a telltale evidence of chronic inflammation. The baby was failing to thrive. The birth weight was 2.56, and when we saw the baby in 3 months' time, or when the baby was referred to me, the weight was only 2.58. So there's clearly failure to thrive, and you could easily attribute that to chronic ongoing inflammation. But interestingly, there was no fever, there were no rashes. However, the baby clearly had splenomegaly. There are 2 centimeter splenomegaly. There is history of consanguinity, and there is family history of FMF. So the question is, there's plenty in this patient to consider a systemic autoinflammatory diseases. But I was very clear before I threw any medicine at her, we had to rule out infection. So they had an extensive infection screen, including TB, brucella, Torch screen, etc., all of which came back as negative. The baby also had a sample sent off to a higher center to look for primary immunodeficiencies. I mean, the biggest worry was skin. Severe communal immunodeficiency, and there was nothing at all. All the lymphocytes and everything were normal. A basic immunodeficiency is negative. And I wondered about bone marrow. When we had a chat with the hematologist, and hematologist felt that this is a sign of chronic inflammation than anything infiltrative. So it could have been a congenital, but they were very clear because of high nude white cell count and thrombocytosis, highly unlikely. This is probably a reactive bone marrow more than anything else. So the question, what systemic autoinflammatory disease should I consider? With the family history, FMF had to be considered, but there was no fever, let alone. But the good upside is it's quite easy to trial something to treat. So what I did at this point in time is I spoke to Dr. Cesar Ozen, who is like an international expert on autoinflammatory diseases, and she said FMF can present like this, because I had not heard about FMF presenting like this, because they see this all the time. She's a Turkish consultant, and she emailed me saying that, Kishore, FMF can present like this. So that's definitely something which we considered. CAPS was another thing. If you remember, I talked about NOMID. This NOMID is a condition which can present in early neonatal period, but there was no musculoskeletal manifestation. There was no CNS manifestation. So that made CAPS highly unlikely, and there was no fever at all. Is it hits? Again, possible, because you can have hits before first year of age, but I wasn't quite sure whether hits can manifest at 3 months of age, or probably from the neonatal age group. But splenomegaly was another thing which this could be hits. Another differential diagnosis, interferonopathies, which I think we'll come to later, but there was no neurological benefit. Basically, interferonopathies, you often get a CNS calcification, other things. There was nothing to suggest that. So with that clinical picture, we sent off the autoinflammatory genetics. And I said we should probably try colchicine. So colchicine was very easy in this patient. In the sense, if it is FMF, the patient would respond. If it is HIDS, it will not respond. HIDS is one condition, periodic fever, which will not respond to colchicine. The baby failed the trial of colchicine. The CRP continued to be high and the weight gain continued to be poor. But the interesting thing is now the baby started having episodes of screaming. So the baby would scream nonstop for about 1 or 2 days and then have these episodes, which the pediatrician felt was because of abdominal pain, which is possible. Again, if it's a diagnosis of HIDS, that is possible. So for a trial, we started steroids during the episode, and she had a good response. And not only that, the steroids had settled down the inflammatory markers and the growth better. And at that time, we had a genetics result coming back saying that this is consistent with mevalonate kinase deficiency or HIDS. And the patient is about to start anakinra, daily injections of anakinra. So that's the last case for me. I'll just have one slide on genetic testing. The disclaimer is I am no expert in genetic testing, but I'm grateful to Dhanya, who I had a quick word with before I did the talk to see what was available in India. So basically, when about 5 years back, we were doing Sanger sequencing, which means it was just looking at one particular gene. So if you found the FMF genes, it looked for that, but it had lower sensitivity and lower discovery power. Whereas in NGS, you are looking at millions of fragments simultaneously, and that gives us much better yield or pickup. And that is quite cost effective if you have got a high number of targets. So what I'm told is NGS is freely available in India in private sector. And I'm told there is no set systemic autoinflammatory diseases panel yet, as far as I know. And that's also probably hampered by the fact that the mutations that are common in Indian population have not been kind of stratified or classified. However, even if you're referring a patient to geneticist, the interpretation of results needs very accurate clinical information. So this is where the clinician works with the genetist to come up with the right diagnosis, like I gave examples for. One word about anti-IL-1 treatment, which is sadly not available in India. The medicine anakinra I was talking about is given as daily subcutaneous injection. And the other one we have in UK is canakinumab, which is given as 4 weekly injections. So just to summarize, how do you approach a child with suspected periodic fever? There is absolutely no substitute for good history. It's very important to ask about family history, consanguinity, and in our situation where we see a multi-ethnic population, the ethnicity is important. Age of onset is very important. Periodicity, how long does each episode last? How often does this happen? So these are the most important questions which we need in history before we embark on any examination. And then you can have symptoms associated with any of these symptoms. And because I've been doing this for a few years, I've kind of got a tick box in my mind. I go through symptoms. The worst one I go for is abdominal pain. And then you can have eye symptoms, throat, mouth ulcers, lymphadenopathy, rashes, chest pain, joint symptoms, myalgia, etc. And it should be able to give you a clinical diagnosis at the end of it, or at least a differential diagnosis. Investigations, full blood count is important. Inflammatory markers are very important. Please make sure ferritin is done as well. Serum amyloid A is helpful, but I don't know whether it's available in India. But as I said, we need to rule out infection. So all the necessary tests which are required to rule out infection is mandatory. Again, we may have to think about immunodeficiencies. That is other differential diagnosis that rules out. However, the most important thing is the timing of the testing is very important. So if you see a patient between an episode, it probably makes sense to see them during an episode so that you can do a clinical and a laboratory assessment while the patient is having the episode. This is a couple of slides I have borrowed from my good friend, Dr. Suma Balan. This was about the situation of autoinflammatory diseases in India and the challenges. I think it's a more challenging clinical situation in setting which much more infections than what we see here. And again, often the patient has been to too many hospitals. There is a limited awareness of autoinflammatory diseases. And again, some treatment modifications. For example, if the patient gets treated for something else with steroids, that may help with the symptoms, but that may not treat the condition. And the families may have received other diagnoses before, and then the financial challenges of getting the testing. And as I said, the Indian mutations are still not reported. So these are some of the challenges in Indian setting, which hopefully we can overcome with collaborations like this in future years. Other challenges faced is explaining the diagnosis and prognosis. Often there is need for long-term treatment, And many of these treatments are incredibly expensive, and there should be a lack of financial support. But most importantly, there is lack of availability of IL-1 inhibitors. So I work closely with one of the anti-IL-1 manufacturers, and we have been kind of pushing lots of UK-based Indian rheumatologists have been pushing them to actually provide anti-IL-1 or make it available in India. If I would say is if you're not sure, you can ask a friend, a rheumatologist, a pediatrician with interest, or you can even email me. Geeta madam, both Geeta madams have got my contact number. If you've got a difficult case, you would me. I am more than happy to help in whatever way. As I said, I'm no expert, but I can share whatever I know about the symptoms in the subjects to try and I will be happy to take a few questions. And once again, thank you very much. I have no words to thank. Thank you all for having me do this. I'm happy to take questions. Thank you very much.
Geeta? Dr. Geeta is there. Kishore, thank you for that wonderful session. And we are having a couple of questions in the chat box. Rather than questions, comments in the chat box. I will read it for you. 1 minute. First one is a comment from Girish Subramaniam. TRAP is TNF related. Doesn't it seem more likely to be an autoimmune disease?
That's a very interesting question. I think that is a debate which kind of has gone on. But one of the reasons, probably the wrong way to explain this, one of the reasons why we think TRAPS is more of an autoinflammatory than autoimmune condition is that anti-TNF doesn't really work for TRAPS. It works temporarily, but if you look at the signs of systemic inflammation, you often have systemic amyloidosis, hyperferritinemia, etc. in these patients. And anti-TNF often, if it works for short term. Sometimes it doesn't work at all. It needs anti-IL-1 to switch off the inflammation in these patients, which is why putting different bits of the jigsaw together, it is leaning more towards an autoinflammatory rather than autoimmune. And as I said in my second slide, it is actually a spectrum because many of them are not clear-cut autoimmune or autoinflammatory. It's a spectrum in between, but this is probably in the middle of leaning towards autoinflammatory in that spectrum.
It is overlapping. Okay, Kishore. Next question is from Dr. Naresh. Prednisolone said to decrease duration between 2 episodes of FAPA. So, if it is justified in it.
Again, it doesn't reduce doesn't increase the frequency in all patients. I must say that. We've had a few patients where it's increased and it's generally accepted that it may increase the frequency. For that reason, I think there is absolutely no harm in trying it because these patients often lose 3-4 days a month of school. And sometimes parents have to stay at home to take care of them, affecting their employment and other things. So I think we need to see that in the larger picture. But because of significant morbidity, I think there is absolutely no harm in trying prednisolone at first. And we are using probably a dose a month, which is not going to have much Cushingoid effects anyway. So I think there's definitely something which is worth trying. However, if it comes to a stage where the frequency is increased to something like once a week or once in a couple of weeks, then we could probably stop it and try them on colchicine because we have got patients with PFAPA who have responded to colchicine. Or you could try a double-pronged attack. So you could put them on colchicine for prophylaxis and give steroids, continue to give steroids for acute episodes. Hopefully that helps.
Thank you. Kishore, little more about Majeed syndrome.
So the reason I didn't particularly discuss about Majeed syndrome is
that
it is not a periodic fever syndrome. It's an autoinflammatory syndrome which predominantly affects skin and bone. So there is a condition which I just described where there is a skeletal involvement, autoinflammatory syndrome with skeletal involvement, what we call CRMO or chronic recurrent multifocal osteomyelitis. Now, Majeed syndrome is a much more severe variant of CRMO with younger age of onset, with significant skin involvement and bone involvement, failure to thrive, etc., who need treatment much earlier. And many of them actually succumb if we don't treat them earlier. That is why I think if you look at autoinflammatory diseases, the whole list, it's an exhaustive list. I had to confine my discussion to periodic fever.
Okay.
However, I'm happy to do another session sometime later to go into the rest of the autoinflammatory diseases, just to give you a flavor of what it is like.
Thank you, Dr. Kishore. Any triggering factors in recurrence of symptoms in periodic fevers?
It really depends on what the periodic fever is. So one of the symptoms I would definitely ask in the history is whether parents have identified any triggers. Sometimes you can get actual infective triggers. Sometimes I've got patient with FM, and I would say a unclassified periodic fever syndrome with abdominal symptoms who has responded to colchicine, who has certain dietary triggers. Now, one could argue this could be abdominal migraine or whatever. I don't know what it is, but she has responded completely well to colchicine. So there can be triggers. And that is one benefit of keeping a symptom diary, is that we can identify this trigger. So one thing I say is, can you please write down what do you think triggered this?
Okay. Whether the normal inflammatory markers, if the inflammatory markers are normal, whether it is reliably rule out an inflammatory syndrome, autoinflammatory syndrome. The question is
I think it almost always does.
Yes.
Because I cannot think of a systemic autoinflammatory disease with normal inflammatory markers. So you can have one or two of the parameters normal, but with a completely normal CRP, ESR, ferritin, one of the telltale evidence of inflammation is raised inflammatory markers. So it would be very difficult to substantiate a diagnosis of autoinflammatory disease in the absence of raised inflammatory markers.
Other question is, I think Dr. M.G. Geeta will answer that question during her concluding remarks. Which lab provide free genetic analysis in India? Next is, how common in periodic fever in India? Kishore,
I really don't know.
How common is periodic fever in India?
It should be there. It should be fairly common with the genetic pool we have. I think it is probably underdiagnosed and under-recognized. And I think the fact that we have got so many infections that we confuse the situation with doesn't make it any easier. But I don't have any literature evidence to suggest what the potential incidence could be. But I think if this talk helps you to think whether this could be a periodic fever, when you see somebody with this symptom complex, I think I've won the battle.
Kishore, even though time is 9:30, I will read 3 or 4 questions more. One is, can primary immunodeficiency coexist with autoinflammatory syndrome?
Yes, that is. It can coexist with autoinflammatory diseases, and it can coexist with autoimmune conditions. So we have, for example, we have a boy with common variable immunodeficiency coexisting with juvenile idiopathic arthritis. No, it may be an arthritis part of CVIA, but the thing, CVID, but in children, if you have got inflammatory arthritis lasting for more than 6 weeks before your 16th birthday, it's called JIA and treated accordingly. So this is a patient who's got a primary immunodeficiency, who is actually on etanercept to treat his arthritis. So they can coexist.
Another question is there any cardiac manifestation found in autoinflammatory syndrome? Question is from
usually
Dr.
not
Faisal.
described in primary conditions, but I think there are case reports of, but there are 2 parts to it. There is clearly an increased evidence of cardiovascular morbidity with increasing age in patients with FMF. There are lots of reports from Turkey say that, which whether that is a baggage they carry because of chronic long-standing inflammation, I wouldn't know. The other thing is, again, if you have got a macrophage activation syndrome complicating one of this, you can get a myocarditis picture, and you can, just like PIMS TS, to be honest, and you can have a deranged cardiac function. But prima facie cardiac involvement as an established picture of any of the periodic fevers is less likely.
The last question is, Kishore, if genetic mutation is negative for FMF and responds to colchicine, with the phenotype of LMF, do we label as unclassified periodic fever?
So yeah, I think it doesn't really matter what you call it as. Because I've had patients who have had a clinical picture of FMF, whose mutation is negative, who have responded brilliantly to colchicine. And I've just called them colchicine responsive unclassified periodic fever syndrome. As long as your patient is better, they do not get renal amyloidosis, they are thriving well, they are growing, developing well, what's in a name? I would just keep colchicine going. The only thing is, if you don't have a genetic diagnosis, you give it for a few years and then you can probably try them off the medicine to see what happens. If the symptoms recur, you need to put them back.
Okay, thank you, Dr. Kishore, for that excellent presentation. And there are many congratulations and appreciation in the chat box. Kindly for you, kindly go through it. I am not in a position to read all, and
That's
it is.
fine.
I definitely know many senior faculty members, including many of respected teachers, are there in the platform. And because of the time constraints, I'm not in a position to unmute them also. With this, I invite Dr. M.G. Geeta, our key organizer of the program, for concluding remarks. Dr. Geeta, please tell about the genetic test availability in India also.
Sorry, Geeta madam, before you say, can I just mention one thing?
Yeah,
I cannot thank you enough for the very kind words and comments my esteemed teachers, colleagues, and have posted in the group. I'm just ever so grateful. Thank you very much. And it's an absolute honor and pleasure to be doing this lecture in this esteemed group presence. So in the presence of these esteemed personalities. Thank you very much.
It was really fantastic, Kishore, listening to you. And this is exactly what we were hoping for, that we have a very colorful and interesting lid opener, so that all of us are now really have our antennae up and want to learn more about the specific other autoinflammatory syndromes. We can't thank you enough too. And next week, we have Professor Helen Lackman from the UCL Division of Medicine. You already mentioned you work closely with her. She would be talking about understanding traps and hits. So it's going forward from here. And we all cordially invite you to be with us next Friday at 9 p.m. And in your talk, you have alluded to the importance of a thorough, meticulous history, and also how important it is to work in tandem with the molecular geneticists, to work hand in hand. So we are actually experiencing this, and it's been a wonderful journey. We're looking forward to more. And there's a question about genetic testing in India. I think we have Dr. Vinod Skaria, who would be the best person to answer that. Dr.
Okay,
Vinod?
okay, Geeta, over to you, Dr. Vinod.
Dr. Vinod, please unmute.
Vinod, unmute yourself. You are still mute, Vinod. Please unmute. Okay.
Hi, can you hear me?
Yeah, you are audible.
Sorry, I missed the question.
Yeah, there was a question about genetic testing in India, how it is available free of cost, what are the ways in which clinicians can access it. So I thought you would be the best person to answer it.
Okay, so the genetic test is available in multiple different formats across the country. Okay, for when you talk about exome sequencing or panels, typically there are a couple of good, at least 2 to 3 private laboratories which are offering it as a service, fee for service, which are quite good. Apart from that, there is the program that we run, which is called Guardian, which is a research program. It's not a clinical service, where we do whole exome sequencing as well as whole genome sequencing in cases which turn out to be negative for whole exome sequencing. But of course, the limitation is that we have inclusion criteria. It has to be a familial case. It has to be, clinically worked up, etc., etc. And of course, the outcomes are, so we want to work with institutes like, for example, Calicut Medical College. We have worked for 5 years to set up the infrastructure to make a diagnosis, and also to build very focused test which can be implemented back in the clinics. Like, for example, For hits, we have a hotspot mutation test on Sankar, which is now implemented in Calicut. So we would always want to work with a center which can actually take it to the end point. And apart from that, there are single gene tests, not many, but for very specific test, very few centers run the single gene test. So that is pretty much the landscape of the genetic test available.
Okay, thanks a lot. I hope that answers the question. So, yeah.
Yeah. Continue, Geeta.
Yeah. So we are really grateful to all our teachers, senior members of the profession, colleagues, and students for being with us and listening to this very interesting talk from Dr. Kishore. So thank you so much to all the delegates. Thanks to Dr. Vinod, Dr. Ajit, Ashraf, and everybody from IAP Calicut, Dr. Nihas, and our hosts, Dr. Ranjit and Dr. Ajay, who have done a fantastic job. It was absolutely crystal clear, the sound and the picture. That we couldn't hope for anything better. So we thank our senior members of the profession so much, Professor Parvati, Professor C.K. Shashidharan, and all the senior faculty members and our teachers who have graced this occasion and made us want to do more of such programs. So thank you all, and see you next Friday at 8 p.m. To listen to Professor Helen Lackman on chaps and hits. Thank you. Good night.
Thank you. Good night to all. Kishore, what is the time there?
It's only 4:15, sir. The whole afternoon was set aside for Calicut IAP, so there is no problem.
Okay, good evening to you.
Okay. It is, we are starting weekend here, so but then there's nothing much to do because of the lockdown.
Yeah. Lockdown. What about the COVID situation?
It is quite bad, mismanaged by government partly, but yeah. I can talk about hours about it, so I'm not starting. Yeah, I think the cases are going up dramatically. They have gone up dramatically in the last 4 weeks, and that this lockdown was inevitable.
Okay. Thank you. Stay safe. Okay.
Thank you to see everyone. It's great to see everyone. Thank you very much.
CK sir, is that okay?
Thank you, sir. We end this meeting. Thank you all.
Okay, thank you. We will end. Thank you.
Ranjit?
Okay, madam.
Okay. Ajay, Ranjit, thank you so much.
Okay, ma'am. Good night.
Nihas?